In this video, I'll be reviewing the recent results that were presented at the ASCO annual meeting in 2024, a few weeks ago, regarding the phase 3 Renaissance, or also known as the FLOT5 study. This study was for patients with oligometastatic disease. Remember, when we're talking about treatment, we're always first at the time of diagnosis having to stage the cancer using imaging techniques and assessing what the stage is and assigning patients to either localized stage 1 to 3 or to metastatic stage 4. In the previous video, we talked about, though, a subgroup of patients within stage 4 that are called oligometastatic that might be able to be treated differently than the classic approach for stage 4 patients, which is referred to as being palliative, which is shown here in this mind map of the strategy of how we treat patients through stage 4 from first line through later lines, incorporating targeted therapies as appropriate, and sometimes using triplet chemotherapy, even in the stage 4 setting for various reasons. In the previous video, we talked about where if we're going to be doing something more aggressive, like in the setting of oligometastatic disease, we prefer to use more aggressive treatment like triplet therapy to really optimize the outcomes. So we reviewed what is oligometastatic disease, what is the concept, and that means that there's only a few sites of spread. And we talked about, though, the difficulty in getting a handle of what exactly should be defined as oligometastatic disease. We also discussed the challenges of how we should define oligometastatic disease because we just don't really know what is the best criteria. What we do know, though, is that the higher the number of sites and or the higher number of spots within a site, the less likely that it should be called oligometastatic disease, because the less likely that an aggressive form of therapy would be helpful to the patient. And so we talked about what the aggressive treatment might entail, which usually includes either surgery or radiation or ablative techniques to ablate certain metastatic sites, and with the intention of removing both the primary source, the spot where the cancer started in the esophagus or stomach, as well as the known and identified metastatic sites. We talked about, again, some ways that oligometastatic disease has been attempted to be defined. This is the group, I think, that has been the most thorough by predefining a plan as to how they're going to come to the conclusion of what should be defined as oligometastatic disease, which entailed incorporating the opinions of 69 experts who treat this type of cancer and providing them with statements, and then getting to see what their agreements were with those statements and coming up with, as optimal as they could, a consensus statement of what should be called oligometastatic disease and what we should do about it in terms of therapeutic treatments. And so that was shown here, this group called OMEC, Oligometastatic Esophageal Cancer Consortium, and they came up with a definition, which is probably the most stringent definition out there, but that's because it was trying to incorporate and getting a consensus of a lot of different opinions, including more conservative positions. And so we also talked about in the previous video other definitions that have been used, because this study, the FLOT3 study, predated that OMIC consortium meeting. And so we talked about the FLOT3 study, and that the arm B of that study was sort of the critical oligometastatic question. And that laid out its own groundwork in terms of what it felt should be defined as oligometastatic disease, and again, which is arbitrary. And this study, we reviewed the results, which enrolled 60 patients ultimately to this oligometastatic arm. And we saw that it included patients with metastatic disease to multiple different sites, and common sites being the liver, the lung, the peritoneum, and metastatic lymph nodes. And we showed the results of that arm B, that their outcomes were better than patients with extensive stage 4 cancer, but not quite as good as would be expected to stage 2 and 3 patients that were in Arm A. And then we parsed out what was going on within Arm B and showed that even though all of these patients were supposedly eligible for surgery and planned to go to surgery after the 2 months of FLOT chemotherapy, a large component, 40% of the patients enrolled to Arm B, didn't get surgery. And we saw that patients who did get surgery did very well with a median overall survival of more than 31 months, whereas those who didn't get surgery were just under 60 months. But we also pointed out that it's important to see why they didn't get surgery, and that was because they had progression or lack of response or death, or became medically inoperable in that interim during the induction FLOT chemotherapy. And also, as will be in these types of studies, some patients just didn't proceed to surgery because they didn't want to, even though initially they indicated that they would go to surgery if they fell into Arm B. And so it was important to point this out, that it's not because of the surgery necessarily that these patients did well. It's because they were selected over those couple of months of chemotherapy for the best acting patient with the tumor that's behaving itself and able to be removed. So the lingering question was, amongst these patients, if surgery is done versus not done, is there any difference? And we also pointed out that different sites within the body have a different overall prognosis. Even though they're all falling under this umbrella of oligometastatic disease, they are different. And so patients that have just lymph node spread tend to do better than other sites like the liver and the peritoneum. And so ultimately, we concluded that this FLOT3 study of Arm B was positive. It was promising. Patients were doing better, certainly, than extensive disease. But we still couldn't answer the question definitively. Was it specifically because of the surgery that they did well, or was it just because we super selected them by, first of all, excluding or separating them from the extensive patients, and then within the Arm B, giving a couple of months of chemo, and then only selecting those patients who were able to get through all of that, and that's why they did well. So ultimately, that's why this randomized study was performed, the Renaissance FLOT5 study by the same group, so that leads us now to the results of that particular study. So this again was performed by the German AIU group, which has done a lot of the FLOT studies, FLOT3, FLOT4, FLOT5, which we've been alluding to throughout all of these talks. And the discussant of this abstract, which came on later after the report of the actual trial results, this is her slide, and I just wanted to show it because this sort of helps us understand the schema of how things are being approached in the stage 1 setting, with surgery in the stage 2 and 3 setting, with chemotherapy before and after surgery because it's more aggressive and we're trying to decrease the risk of recurrence. This again will be a separate video in the future that is discussing the results of the FLOT4 study. And so now we're talking about in the stage 4 setting, which is not considered curable or amenable to a surgical approach. Is there a subgroup within this stage 4 group, namely those oligometastatic patients, that could be treated with a surgical resection with a more aggressive intent, a more curative intent? And so this is what's called the study flow chart, where you can see that patients that have metastatic but limited gastric or G-junction adenocarcinoma are medical and technically operable of the primary tumor. Metastatic lesions are resectable or can be controlled by local ablative procedure, and no prior chemotherapy and no prior tumor resection. So this was not a trial that enrolled patients who had a prior surgery and then sometime later had recurrence and fit into the category of oligometastatic disease. Those patients weren't eligible. Patients had to have synchronous metastatic disease at the time of their first diagnosis and fall into the category of oligometastatic or limited disease. And if they did, patients would all get 4 cycles of FLOT and then restaging. And if patients had progression at that time point, or for whatever reason were no longer eligible, not considered a surgical candidate, would not be continuing and would unenroll from the study. And of the remaining patients would then get randomized to the standard of care, which is to just continue more systemic therapy versus getting surgery of the primary tumor and metastatic sites, and then follow up with post-operative chemotherapy as possible, as tolerated, for up to 8 cycles, and then follow up thereafter. And the patients that were planned to be enrolled was 271, as you can see here in this bubble. And then with the planning that it was expected that there would be some dropout after the first couple of cycles. We've seen that in the FLOT3 study where a lot of patients fell out here and weren't eligible for surgery at this point. And so now only patients who were still eligible after that point were to be randomized, and they needed 176 patients in their statistical modeling to assess this question with their predefined statistics. And so it's important to note, though, that actually this was the planned sample size is 271 so that you can have 176. But the trial accrued a little slower than intended. And the reason for that, you might ask, is how can that be? Like, this is such an important question. It's so common. A lot of patients have this question. But one being that, there are definitions for oligometastatic disease, and if they're not met, then you're not eligible. But secondly, many patients either had the preconceived notion that they wanted to get surgery no matter what, so they wouldn't want to enroll in such a study that had a 50% chance of not getting it. And other patients would maybe not want surgery no matter what. And so they wouldn't want to enroll because they may be randomized to the arm that was intended to get surgery. And so this is a select group of patients that basically were willing to leave it up to chance that, I may or may not get surgery. It's a 50% chance, and I'm willing to enroll in that. And so that's difficult to enroll to such studies. These are known challenging studies when you have an intervention like surgery with or without surgery. And so it's a super select group of people who are willing to undergo this. So regardless, it was a slow accruing study, as I mentioned. And so they actually only enrolled 182 instead of 271. But because this study was left open for longer, they had 141 randomized. They didn't get the 176 that they originally intended. But again, because the study went on for longer, this was sufficient to answer the question that was being asked. So even though it was supposed to be just almost 90 patients in each arm, they got around 70 patients in each arm, which again, with this type of study is really impressive. So the other thing over here to note is that patients with gastric cancer and G-junction adenocarcinomas were enrolled, and stratification means that the statistician assigned patients to each arm, making sure that there were equal numbers in both sides of stomach and G-junction of patients who had a response to the FLOT that they got preoperatively, or just stable disease. So there was the same number of stable on both sides versus responders on both sides. And there was also an intentional stratification of the site of metastatic disease, so to make sure that the better prognostic patients, those that had just lymph node metastases, was even on both sides. So that's what stratification is that we're making sure that things that we know might make a difference in the outcome are equal in both sides of the study, both arms of the study, so that if there is a difference noted, then we can say it's not because of these things, because we balanced the arms for those key variables. Okay, so this is the study design. And so again, the whole point of having this control arm is that we're using that there because we are super selecting these patients. These patients are, first of all, very limited disease for metastatic. They have now received 4 cycles of FLOT, some of which have progressed on that, some of which have fallen out of the study for other reasons. And so now we're just talking about the patients who made it through all of those bottlenecks. And now we're randomizing so that amongst that really good group of patients who are now going to just continue with standard systemic therapy, as would be considered standard, we're going to introduce surgery for them and see if there's a difference in outcome. And if there is, then we can be more confident that it's from the actual surgical intervention as opposed to all these other bottleneck steps. And so if we don't have this control arm, like in FLOT3, they may just be doing well just because of their selection and not because of the surgery. Okay. I went through the actual definition of what they called oligometastatic disease in the previous video. It's the same criteria as the FLOT3 arm B, and it's all listed here. Basically, lymph nodes, retroperitoneal lymph nodes, and or a maximum of one organ listed here, including peritoneal disease, as long as it wasn't extensive peritoneal disease. And so again, I'm going to point out that this is different than the OMEC consortium definition, the OMEC being more stringent, where basically it's not and, it's either or. You can't have both lymph nodes that are metastatic and a distant site. It has to be one or the other. Another one is that with OMEC that they would not include peritoneal disease. So just remember that this is a little bit more lenient definition of oligometastatic disease. The primary endpoint of the study was overall survival. Is there a difference in the two treatment arms? And can we attribute that to the introduction of surgery in arm A? And then there are a whole bunch of important secondary endpoints like quality of life and survival amongst the different sites of metastatic disease, for example, which we'll show here today. And then there's also, as I'm going to show you, per protocol analysis set where you're going to see that some patients, even though they weren't supposed to, in arm B, which was supposed to be just continuous systemic therapy, actually got surgery. And so intention to treat means we're going to analyze this study based on the two arms that you were randomized to. So even though you had surgery, if you're in arm B, you're going to be assessed as if you didn't have surgery. That's called an intention to treat analysis. But then a per protocol analysis is saying, okay, we acknowledge that you were randomized to arm B, and by intention to treat, we have to assess you that way, but you got surgery. And so we're going to now do a per protocol analysis and just look at people who didn't have surgery in arm B. And if someone who was in arm B got surgery, we're going to put you in arm A and assess you as if you got surgery and see what the outcomes are. So I point that out here because it's important for this particular study. And so you can see here there's a lot of things going on, but ultimately what's most important to us is, does this change the trajectory of a stage 4 patient with oligometastatic disease? Does it improve overall survival? Some of these others secondary endpoints like how many patients got radiation therapy versus surgery wasn't reported yet in this particular report so far. So this initial presentation is only talking about patients who did or didn't have surgery and with the primary endpoint survival. So I showed you how many patients were actually enrolled and then how many patients who actually got through the FLOT and then were randomized, so 141, and then 139 of the patients enrolled were analyzed. This study ran from 2016 to 2023, and then the analysis was just done recently, a few months ago. So you can see here the two arms. Arm A was FLOT with surgery, arm B was just FLOT. You can see that the gender makeup, the performance status, the site of the primary tumor were equal in both arms, which is important. That's what randomization typically does, is it evenly distributes all the different variables that could make a difference in outcome. And so we're happy to see that it looks equal and balanced. Same thing with the sites of where the metastases were, retroperitoneal lymph nodes only, evenly distributed. About a fifth of the patients had that. You can see here that a lot of the patients, about a quarter of the patients, had peritoneal disease. There's a slightly higher percentage in the FLOT only arm compared to the surgery and FLOT arm, but similar. And then you can see liver, again, is a very common subgroup. And again, relatively evenly distributed. And then a spattering of other sites that you can see listed here: ovaries, Kuchenberg tumors, adrenal glands, other lymph nodes other than in the abdomen, like the supraclavicular lymph nodes, bone, etc. You can see here the different pathological groups, the high grade versus low-grade or well-differentiated tumors are evenly distributed, relatively speaking, and the subgroups like diffuse type gastric cancer versus intestinal type. So the summary of all of that, and this is from the discussant slide, is that it is a very heterogeneous group of patients, which we knew about. We know that they have different sites of where the primary tumor started. They have different sites of where it spread to, which can have differences. But ultimately, the importance of randomization is that it equally balances these groups across the two treatment arms so that they're the same numbers of them there, so that if they do have differences in outcome, at least they're the same in both arms. So now we're set up to assess, is the introduction of surgery going to provide any benefit here for these particular patients? So what happened? So between the two arms, you can see that for the first 4 planned cycles, those that were given before patients were randomized, all patients got all 4 of those cycles. And then patients were randomized to arm A and B. And you can see here now how many percentage of patients completed the post-randomization cycles. So in arm A, the patients that get surgery, you can see that the rates are quite low of the patients who actually get all 4 cycles. These would be being given after an intervention like surgery. And so it's always difficult to get in post-operative chemotherapy, especially FLOT. And you can see here that less than 50% of patients were able to get all 4 cycles. In contrast, patients in arm B, which are not supposed to be getting surgery, you can see that the completion rates are much higher of getting those first 4 cycles, and certainly the next 4 cycles as well. So, very few patients got all 12 cycles, even in arm B. And that's just because of the cumulative toxicities, namely neuropathy, where some of the drugs are probably being dropped here along the way. And also there's some progression as well in some patients, and they're stopping and changing to other treatments. So the main point though here is that less chemotherapy is being given to the patients who are in the surgery group, probably because of some patients not being able to get it post-surgery because they're still recovering. Okay. This is the slide to show the end of study treatment and what patients got after they came off the first line of therapy. And so you can see that the reason for the end of therapy was slightly different between the two arms. In the first row, you see patients who completed everything planned. And so of those 12 FLOT cycles with or without surgery, if you're in arm A, and you can see that fewer patients completed all of the planned therapy in arm A. You can see that the patient Wisher toxicity was similar in both arms, but that there was a higher rate of recurrence or progression in the patients who were in the surgery arm. And that's probably due to the fact that patients got less treatment with systemic therapy while they were getting their surgeries. And so they were having discontinuation of their treatment, which allowed the cancer to progress. And the death rate was higher in the arm A group. And that again is thought to be due to post-operative complications, post-surgery complications. And then you can see that the percentage of patients who got next line therapy was higher also in arm B, again, potentially due to the fact that these patients are well enough to continue on, whereas some of these may not be. In contrast, there may be some patients who were doing so well after this intervention and they didn't need to get a next line therapy yet. So there's a combination of that going on. So what else can we discern from the data? We see that the patients randomized to arm A, most of them got surgery attempted. Those who did not, it was a small percentage, 6%, decided not to. So even though they were enrolled in the study, they were willing to do a surgery if they were randomized to A, ultimately when it came to it, they decided not to. And so, of course, a study is a study, and we always will respect patients' wishes. And that's an important point here, is that always you can change your mind. And in this case, a few patients did. Some patients had progression that precluded their ability to go on to surgery. And then ultimately, of the 61 who had an attempted surgery, 59 had some form of surgery performed and executed. And interestingly, though, in Arm B, as I was alluding to, even though the patients randomized to Arm B were patients that were supposed to not get surgery and just get systemic therapy, systemic chemotherapy with FLOT, 15 or 21% of them went on to get a surgery. And so, again, this highlights the point that even though patients came into the study and said they were willing to not get surgery if they were randomized to B, ultimately the patient and their physician elected to proceed anyway. And again, it highlights that you can change your mind in a study, and it's more always about you and your wishes rather than a study's protocol. So regardless, you can see that of the 15 patients that did get their surgery done, 15 of them had some form of surgery performed. Now, what surgery was performed? This is a very important slide, okay? So it's divided in the top to the patients who were had lymph node metastases only, and in the bottom to the patients who fell into other category. And you can see that amongst the patients who had lymph node only metastases, most of them had a surgery attempted. And interestingly, though, only 56% of those patients actually had removal of both the primary tumor and the metastatic site. A subgroup of them, 38%, had only the primary tumor removed, but not the metastatic site. And similarly, in the group B patients who were not supposed to get surgery but did, there were 4 of them that had lymph node only disease. All of them had surgery, but only one of them had both the primary tumor and metastatic site removed, whereas the primary tumor was only removed in the remainder of them. So a low rate of patients getting resection of both sites. In the second subgroup, you can see, which is a larger group of patients, 45 patients in Arm A, you can again see the same phenomenon, though, that only around half or just over half got surgical removal of both the primary tumor and the metastatic site, and a large proportion just addressing the primary tumor, but not the metastases, and a few patients getting just the metastases removed, but not the primary tumor. So again, you see the same phenomenon in Arm B patients who got surgery, even though they were in Arm B. So the obvious question, and the question that the discussant asks, is why such a low rate of patients getting the intended resection of both the primary and the metastatic site? Isn't that the whole point of all of this? A couple of things to say. I mentioned earlier, the physician team at a multidisciplinary tumor board would be making the decision of how they would address the primary tumor and how they would address the metastatic sites. And they had at their disposal not only surgery, but also radiation or ablative radiation. And so, like I mentioned, the authors have not reported the incidence and rates of how many patients got ablation with radiation here. So maybe some of them got ablated rather than having surgery. In addition to that, similar to the FLOT3 study, even though patients were intended to get surgery, and when they go in and explore to do the surgery, maybe it's not actually resectable or removable, because once they get in there, they realize, oh, it's wrapped around a major blood vessel, or a countless number of other potential reasons why a surgery could not be performed safely and adequately. And so, in addition to that, which wasn't really mentioned or discussed, but is possible, is that many times the 2 sites that are planned to be removed surgically have to be done in a staged procedure, meaning it's not all done at the same surgery, at the same date. Sometimes you have to do one surgery first, get that done, remove the primary tumor, for example, let the patient recover, and then reassess how things are going, and then address the metastatic site with a second surgery sometime later, weeks or months later. And so, if that's the case, then there may have been progression of cancer in that interim while the patient's recovering from all of these things and not being able then to address the second surgery. as an example. So we don't know that information yet, but certainly that could have happened, happens in these types of studies. And so we need to see how things fell in terms of what the rates of patients that fall into each of those different explanations I just went through. So regardless, it's not ideal that the primary tumor and the metastatic site are not both being addressed. That's what we're trying to do. But in all likelihood, the reasons why it wasn't done is because they weren't unable to for some reason or another. So, in addition to that, there were complications due to surgery in a large proportion of patients who went to surgery, both arms of the patients who went to surgery, even in arm B. The complication rate was 40 to 60%. The types of complications were surgical complications or medical complications, or both surgical and medical. Some required repeat surgeries to revise what was going on or to address a new issue that emerged after the surgery. And then there was post-operative mortality within 30 days and within 90 days in these particular patients. So this is the outcome of the study, the primary endpoint in the intention to treat. So intention to treat, meaning again, these patients in arm B, some of them, 15 of them, actually went and got surgery. Most of them were just of their primary tumor, but without the metastatic site. But you can see that they're included in arm B. And what we see and what you're looking at is the control arm, the patients who got just chemotherapy, is arm B, and it is the red curve for survival. The blue curve are arm A, those patients who were intended to get oligometastatic. And what you see here is a classic crossing of the curves, where you see initially patients are living longer with the arm B, and they are living potentially less in arm B later on. So there's a crossing. Some patients seem to derive some benefit from the intervention of the surgery that you see here on the far end, where the blue curve is higher. And some patients look like they did not derive benefit. In fact, it looked to be detrimental to go and get surgery compared to the control arm. And these would be the post-operative complications. These would be the patients who had quick progression because they had to stop the chemo and now they're getting a surgery. And so the discussant highlights this, that there were higher rates of chemotherapy discontinuation in the surgery cohort, which likely contributed to this early death rate. And there were post-operative complications that were high. Some required repeat surgery, and there was a relatively high 90-day mortality post-operatively. So unfortunately, this is not what we wanted to see, but was always a concern to many of us, that if we're doing this, we want to make sure it's actually helping people. And so the concern has always been that doing these types of interventions are invasive and cause complications, cause death, and also make you stop the treatment that we know is helpful to you. And this is what we saw here, at least initially, in a lot of the patients. Now, if you got through all of that without a complication post-operatively and your cancer didn't grow, then it does seem like there is somewhat of an advantage to going in the surgery arm. But again, the numbers here are small, and we're like just focusing and cherry picking out some results that we have to be very careful that we're not looking into it too much. So again, we're going to bring up the fact that this is sort of an unfair comparison, though, because some of these patients in arm B actually got surgery. And so, it would dilute out a benefit if there was a benefit, because both arms are getting it. So, as mentioned, a per protocol pre-planned analysis was done, where the patients who got surgery in arm B were then added to arm A and assessed as if they were in arm A. And so you can see the numbers switch around here because of that. And so here in this curve for survival, you see that maybe the detriment that we saw initially is muted a little bit. So it's not as dramatic, but there's still a drop in survival post-operatively in the patients who are getting surgery. And then the benefit at the far end seems to be a little bit more accentuated also. And so It's a little better, but it's still not statistically significant because there's a whole bunch of patients that appear to be not deriving any benefit from this, and in fact, actually doing a little bit worse than the control arm. And that sort of balances out the benefit that's seen in some patients compared to the control arm. So overall, this is a study that's considered negative. What about subgroups of sites of metastatic spread? Was there obvious differences in outcome between them? So we have lymph node only in the retroperitoneal abdomen, we have liver metastases, and we have peritoneal metastases. And so what you do see is that, again, we have, first of all, have to be very careful with some such analyses, because when we do this and break them up into subgroups, we're talking about really small numbers of patients. And when you go back to our video on clinical trials, we know that the more numbers of patients, the more confident we be about the results. The fewer numbers of patients, the more subject we are to random variation, and we can't be as definitive with our conclusions as to what we're observing. So with that notion and understanding, we can still look at it to see what's happened. And what we see is, first, let's look at the lymph node positive subgroup, is that they still have a drop, even though we know these patients tend to have a good prognosis, better than even any of the other patients that have oligometastatic disease. We see that the patients who went to surgery in blue, there's a detriment early on. More patients are dying quicker right around the time of their surgery compared to those who just stayed on chemotherapy. But then there's a flipping of the curves. And again, there's this subgroup here that seems to have derived some benefit from the surgery. But overall, as a group, unless we can identify who these patients are, going into it, we would say that, your chances are just as good if you're just getting systemic therapy, because there's a really high death rate early on. In addition to that, can we really be confident this is real with such few patients? And so it's not a definitive conclusion, but ultimately it's not obviously better. In the liver metastases subgroup, the thing I would really point out is that both arms do very well, like double that you would expect from a stage 4 group of patients with extensive metastatic disease, or any first line study has a median overall survival that ranges between 11 and 14 months. So this is substantially better even in the arm that is not getting surgery. And that's the critical thing to point out here, is that both arms do well, and there doesn't seem to be any difference between the two arms. And in fact, there's an early death rate in the patients who are getting the surgery compared to getting systemic therapy only. So again, the importance of that control arm shows, yes, these patients do well, but it's not because of the surgery. And then finally, if we look at the peritoneal group, that patients who have just peritoneal metastases, unfortunately, what we see is that patients who had the surgery did worse across the board throughout the surveillance period, compared to the patients who just had systemic therapy. And so this one shows that actually the intervention was actually detrimental in all the patients. So what did the discussant point out? The same things that I did, that, numerically at the end of this curve, it looks like some patients seem to have a benefit in survival that gets surgery compared to just chemotherapy. But at the same time, these numbers are quite small out here. And so to really be confident about that, we would probably need to do a bigger study of just patients with retroperitoneal lymph node metastases to really feel confident that the surgery is helping these patients. She also pointed out that the survival rates in the liver metastases patients was excellent in both arms, and probably a function of the fact that these patients are super selected patients and had nothing to do with the actual surgical intervention in the blue arm. And then finally, the peritoneal disease doesn't look so good. But I should point out that these patients were not getting HIPEC. They were just getting surgery of the primary tumor and metastatic site in the peritoneum. And so, as most of us feel, that patients with peritoneal-only disease should be treated sort of separately in separate studies. And probably, if you're going to drive benefit, has to have complete cytoreductive surgery of the primary tumor and any metastatic sites, but also intraperitoneal chemo. And there are studies assessing this prospectively, and I would follow that very closely, and sort of not weigh too much on this because, again, intraperitoneal chemotherapy was not given to these patients with peritoneal metastases. So the final conclusion of the authors was that the Renaissance study, unfortunately, did not meet its primary endpoint, which was to improve survival in patients in Arm A, those who are getting the surgery. And it does confirm that patients with limited disease, as defined by the FLOT3 schema, had overall a better prognosis compared to, say, patients who don't have limited disease. But this was not because of the surgical therapy. And we can say that now because we had a control arm that was just going and getting systemic chemo and not getting any surgery, and they still did well. And so I think most of us will conclude that there is some positive signal there, especially in the retroperitoneal lymph node only disease, and that should be a focus group that then should go on to get similar studies, but more patients so that we can really feel confident that we're helping those patients. And at the same time, they should not be lumped together in the same study, different sites of metastatic disease, because they are actually quite different. And so the reason why we think that this study didn't work, I think can be attributed to a couple things. One is potentially the definition of what is oligometastatic disease is too lenient. As I pointed out in a few slides and now in this video and the previous video, that different definitions can be more lenient or more stringent. The OMEC definition of oligometastatic disease is more stringent. And, my opinion would be is let's focus on that first. And, let's see if this works here, because if it doesn't work here, it's not going to work in a more lenient definition. Let's be as stringent as possible, see if it works, and then we can address a more lenient definition later if it does work in a more stringent definition. So that may be one reason that was not successful, in addition to including patients from different sites of metastatic disease, which actually behave quite differently. So let's focus on one that actually have a positive signal in this study going forward. And then down here in the second bullet is really summarized here, is that a lot of patients were unable to get removal of all of the known disease sites, even though they were intended to, and they got through all the FLOT pre-surgery. They still weren't able to get surgery of their metastatic lesions. Post-operative complications in patients who did have surgery, which we know is a problem, which is why we want to spare this modality of treatment in patients who we think it's not going to help. And then finally, patients who are getting surgery have to stop their systemic chemotherapy during that time and also for their whole recovery. And that allows cancer cells to grow if there are some outside of the oligometastatic sites that were addressed surgically. And so this is one of the main concerns why we don't want to just routinely do this in our patients. And for all of these reasons are contributing factors why we think this trial was not successful. So I wanted to end in a more positive note, as did the discussant here, is that surgery we know is an invasive modality. And that's why we are very hesitant to use this in the setting of oligometastatic disease, where the risk of recurrence is so high, and that we don't want to do more harm than good, as we saw here with the curves of the survival curves showing that a lot of patients were dying sooner after surgery than if they had just stayed on chemotherapy. And so what else can we do? I mentioned that the FLOT5 Renaissance study here did allow for ablation with radiation, but they haven't reported those results as to which patients got it and how they did and how they fared. But the good thing about radiation is that they can focus it just at the sites of where there's cancer, at those oligometastatic sites. And so these types of ablative doses that are really focused have relatively low side effect profile. and they can control the cancer in that location usually pretty well. And the advantage also is that you can treat multiple different sites simultaneously with this radiation, as opposed to with surgery. It's challenging to do that. And I talked about having to do sometimes staging surgery. So in different stages, first stage, you do this area, second stage, you do a different oligometastatic site, for example. And so all of this is pointing to the fact that with radiation, you don't need to take really long breaks from the systemic therapy, which we know are really important in controlling the cancer. And the radiation can actually be synergistic with immunotherapy and also even just chemotherapy. So these would be the rationale to consider a study addressing oligometastatic disease, not with surgery, but with ablative radiation. So this is that study I was referring to. It's called EA, or after the group ECOG Akron, one of the cooperative groups, 2183. And there's the number that you could search on clinicaltrials.gov. And this is, again, an ongoing study. And so patients that meet the criteria that, again, are specific to this trial, that are different than FLOT3 and different than OMEC, but you can see some of them are pointed out here, particularly peritoneal disease and brain metastases, CNS or central nervous system metastases are not allowed to enroll in this particular study. But otherwise, if you meet the definition and you have as at least 3 months of chemotherapy, if not 6 months, then restaging and everything still stable, no progression on the scans, then you'd be eligible to register and get randomized to continuation of that systemic therapy, which is standard, versus addressing that oligometastatic disease with radiation therapy. So this was a presentation about a very important study addressing oligometastatic disease called the Renaissance or FLOT5 study. It was a follow-up study that was randomized after the FLOT3 study preceding it suggested in its Arm B that addressing oligometastatic disease with surgery could benefit patients. However, what we saw in this randomized study, unfortunately, was that in the group that was randomized to surgery, there was an early death rate because of post-operative complications and potentially because patients had to be off the systemic FLOT chemotherapy or derivatives thereof, like FOLFOX, and so the cancer had progression. On the other hand, there were some patients, particularly in the subgroup that had lymph node only metastases, that seemed to at least drive benefit in a subgroup of those patients. Even in that group of highly selected lymph node only disease, there was still an early death rate after surgery for the reasons we just discussed. And so overall, the study was not positive. And the things to take away are that these patients tend to do better than the average stage 4 patient because they have limited disease. But they don't do better because of a surgical intervention. They do better because of the better prognosis of the disease. And we saw that importantly in this study with the control arm. So stay tuned for the following studies where we're going to be focusing on earlier stage disease, stage 2 and 3, locally advanced, and how to optimally address those patients. Thank you.